Hi, I'm Dr. Ashley Fuller.
And I'm Dr. Meredith McClure.
And this is Labia Logic,
the podcast that's all vulva, no filter.
We're here to talk about all the stuff your doctor rushed through, the questions you've been too embarrassed to ask, and the sex ed that barely mentioned the vulva.
Because too many people are suffering in silence with painful sex, menopause misery, and vulvar issues no one talks about.
No shame, no stigma, just real talk, real answers, and the education you should have gotten in the first place. Hello and welcome back to Labia Logic. We're happy you're here. I'm Dr. Ashley Fuller. This is Dr. Meredith McClure, and this is part 2 of our series called Missionary Impossible. This time it's personal, and it's about painful sex. Today we're going to be talking about Vestibulodynia, and we've titled this Ouch at First Touch, or When the Front Door is on Fire. And so let's jump into what is Vestibulodynia, Meredith.
We've talked about the vestibule and how both you and I are rather obsessed with it, and so many problems, especially when it comes to pain in the vulva, originate in this area. And it's just right at the opening of the vagina. It doesn't go past the hymen, and it's just literally 4 to 5 millimeters, if at that, in width, and goes in around the entire opening. And things that people will say so that you kind of know when there's a problem there, especially from a pain perspective, is anything that goes in your vagina is going to hurt. Right at that opening, yes. We will hear ring of fire, we will hear ground glass, and that should be kind of the red flag that you really need to have this evaluated by someone who understands this condition.
I have to say, if you're a clinician and you're listening to this, we didn't learn about the vestibule in residency. I never had heard that word until I was practicing sexual medicine. But it is 90% of the time that patients tell me they have vulvar pain, especially pain with sex. It is right here. This is the money. This is where the root of the problem, almost always, if there's painful sex. We call it vestibulodynia, and like Meredith said, it is this strip of tissue that goes all the way around the opening of the vagina, doesn't go past the hymen, and it has so many nerve endings. It also has tons of hormone receptors. So you may have listened in our previous episode in this Missionary Impossible segment about genitourinary syndrome of menopause, or just how hormones affect this vestibule. But today we're going to talk about how nerves affect this vestibule, because the vestibule has tons of nerve endings also. And as Meredith alluded to, this is something that some people will notice their pain here as a child. This could be something that they get their first period and they can't actually put anything in the vagina. Ouch at first touch. They try to put something in and they can't even put their finger in or put a tampon in. They're the people that come to us and say, I've never been able to insert anything. It hurts too much.
Yeah, it can even hurt so bad that it's hard to sit. I had a patient recently, and she was sitting in front of me and bent over to pick something up off the ground, and that really incited a lot of pain for her at her vestibule. So this can be very debilitating for so many people, and they will go sometimes even years, see many different clinicians, and not have the answer to their problem. And it's important to understand this as patients and as even practitioners to know when this is happening and how to evaluate and even treat it.
Yeah, definitely. So vestibulodynia means pain at the vestibule. So we've talked about what the vestibule is. A lot of what we see with painful sex is what we call localized provoked vestibulodynia. So this means it's not all over the vulva. It's just localized to the vestibule, and it's provoked, meaning that it's with touch. There is unprovoked vestibulodynia. So that's kind of what Meredith was saying. If you're leaning over or wearing tight pants, that's kind of unprovoked. No one's really touching it, although pressure, is there. But if it's with touch, then we call it provoked. And sometimes we talk about this as LPV, the localized provoked vestibulodynia. Again, terms I never learned in residency. So what common symptoms people have is a burning, stinging, or rawness. It really prevents penetration. It prevents any pleasurable penetration. It can be just really, really challenging for these patients to have sex, even wear tampons or put anything inside, even especially go for pelvic exams, things like that.
Yeah. Vestibulodynia, the dynia part is pain, is what that means. And just a note that you should never ever have pain with penetration or any kind of gynecologic exam. Anything going in the vagina should never hurt at the opening. So if you do have that, then you really do need to seek help. And there is ways to help with this. And this episode is specifically talking about the nerve pain, but it also, we've talked about in the first installment of this series how hormones are so important. But this is just more dedicated to the nerve pain. And basically, we think of nerve pain. I think you'll agree that there's kind of two ways to look at it. And I always tell patients, like, it's something we want to know, have you had it forever? Like you mentioned from the first time you put a tampon in, that's kind of normally the best way to kind of gauge that. Or is this something that just came up all of a sudden? And that's kind of like that fork in the road when people come with these problems, and that's what we will ask them. And that fork in the road will lead to different roads in how we evaluate and treat.
Absolutely. So I think there's like these two paths. And we say like congenital, like you're born with it. This has always been a problem. These people who've never been able to put anything inside, can't wear a tampon. And they were probably born with extra nerve endings in this vestibule. And, we know if we actually biopsy these vestibules or remove them, and which we'll talk about later, that they, under the pathology, from the pathologist, they have excess nerve fibers there. So people are just genetically born with just more nerve endings there.
Like 10 times more nerve endings we find than the average person. And we've talked about the vestibule, and it has nerves, it has hormone receptors, but the origin of this little strip of skin is ultimately bladder tissue. So some people will not really even have pain per se, but they'll have persistent bladder symptoms of urgency, frequency. I feel like I have UTIs. I go to my doctor and they don't find any bacteria in my urine. Why is this happening? And they might be told they have interstitial cystitis. That's something we hear frequently with this. But really, when you examine them, you realize it's actually coming from their vestibule.
Right. And then the other path that this can come from, and this is like kind of an origin thing, is people who had normal sex lives, had normal tampon use, just living their normal vulvar lives. And they suddenly had something happen. It's like one of the questions I like to ask, like, everything was fine until when? And these people usually know exactly what happened. And it usually has something to do with some inflammatory insult. So there was some recurrent yeast infection or a UTI that didn't get treated because no one knew it was happening. And then they took antibiotics or they used a monostat and had some kind of reaction to it. And so there was some inflammatory insult that happened. And these nerve endings basically became on fire.
Yeah. And something with that inflammation response, we know, makes those nerves grow more in volume and creates this pain, and also sometimes the bladder symptoms. And sometimes it's both pain and bladder symptoms. It's horrible when it happens to them.
Yeah, the way I think about it is like the inflammation causes all these cytokine production or like inflammatory hormone production that brings more blood flow to the area. And then your body creates these new nerve endings. And so you get more nerve density. And then it just becomes like a loop of like more inflammation, more pain, more inflammation, more pain, and just very hypersensitive. And but I always ask patients, like, everything was fine until when? And they usually have an exact answer of like when the tables turned for them. I think of this in two ways, like how sensitive these nerves are, like in the vestibule, but I also think about how the brain interprets these nerves. Like there's two parts of it, right? Like these nerve endings are super sensitive, but they're also like telling the brain constantly, like there's pain here for like, things that shouldn't be painful. But then the brain starts to amplify this because that's how our pain works. We get kind of like a central sensitization where it like amps up this message about pain, and so it kind of becomes this like downward spiral of pain.
Yeah. Like I always did, think of sex and pain disorders in the vulva. I always kind of, when I'm looking at a patient, I'm thinking to myself, I'm going to look from the bottom at the vulva to the top and back to the bottom. So how that goes from my vulva to my brain and back down, and what that brain, how it interprets, there's often, kind of almost collateral damage, if you will, when the brain really starts amplifying and sending these responses. You would think your brain's supposed to protect you, but in this sense, that protection that it's providing is often very counterintuitive to the healing process.
Right. Absolutely. And then, as with any kind of pain, we start to, like think about the pain more. My patients who come in who have this often, especially if it's unprovoked, like it's there all the time, are thinking about their vulva all the time. Like, they're in pain. And so they're constantly checking in on their symptoms. Like, is today going to be a good day or a bad day? Am I going to be able to do these things I want to do today? Or is my pain going to stop me from doing that? And you become hyper aware of any little thing down there. And this is the hard part about having any kind of pain, but specifically this vulvar pain, where it's just, you are constantly aware of your vulva.
Yeah. And I think there's a difference between certain types of pain in the vulva. Like this is more what we would call a neuropathic, or it's something wrong with my nerve pain, versus I had an infection pain, or I have I don't know, like a pimple, or, skin disorder. It's like, it's not necessarily that. There's neuropathic pain it's different. I mean, you would agree with me in what that looks like.
Yeah, absolutely.
Yeah.
Yeah. And I will say that some people, have recurrent infections. It may not be just one infection for when things changed, but recurrent infections. Sometimes I have patients who have recurrent vaginitis symptoms, recurrent yeast infections. And at some point we cure all the infections, but they still have pain. And often they're like, I still have this infection. And I think I have to have that conversation of, we've transitioned from like recurrent infections to actually a pain syndrome, where those recurrent infections have caused this nerve response that's giving your brain the signal that there's still an infection there, even though it's gone.
And it's going to be just localized right to that area. And
yeah.
And sometimes though, when the brain does get involved, it can give you mixed signals that aren't necessarily true. Where we see allodynia, which basically means something that used to feel normal to me doesn't really feel normal anymore. And this is when all of a sudden someone says, I can't wear jeans anymore. I can't wear underwear because the seams are bothering me so much. And that's a sign to me that, oh, this is definitely more of a nerve process and the brain is getting involved. You also might have other feelings, like something's on your skin, like ants are crawling on your skin. You could feel like there's an object in your vagina or even your rectum. And it's just that the brain is telling you things that aren't really true. And, the feeling of objects in the vagina or the rectum, those muscles that are down there are circular. And that's why it feels like that. Of course, we always have to look and make sure there is no rock in your vagina. But most of the time there's not. And but those feelings are coming from the brain and the nerves.
So Meredith, walk me through what it's like when somebody comes in and they have this history. Either they, like, let's just say they're someone who's never been able to put anything inside. Tell me about how you evaluate them in an exam. Like, how do you diagnose this?
One of the most important things, like we just talked about, is you have to listen, validate and listen, and tell me your story. When did this start? And has it been there your whole life, or did it have an inciting event? And then utilizing that tool, talking about hormones and, where are you coming at me from a hormone standpoint, as far as, are you still getting your period or in birth control pills? Because that can be a component there as well. And then we have to do an exam. I mean, you have to look at the vulva. And so many people go to other providers when they have pain here, and they literally put in a speculum in their vagina and they look inside and they don't see anything and they say you're fine. But what they're ignoring is that little strip of vestibule. And our biggest tools that we use in the clinic is a Q-tip and a mirror to show the patient, like, this is where your issue is. Because it's very easy to see the vestibule with a mirror when we show you in the clinic. And I use a Q-tip, and I will just touch with the Q-tip in that vestibule, and touching on the tissue. I touch on the gland openings that are kind of at 10 and 2 and 4 and 7 o'clock, and say, does this hurt? And if it is, that entire circle is painful to the touch with that Q-tip, that's really the sign that this is vestibulodynia. And then delineating, is this a hormone process? Is this a nerve process?
All right. So I agree that the Q-tip is like one of the most important diagnostic tools, like trying to isolate where pain is. And I think using a mirror is one of the best things, showing patients where their pain is, because our vulvas are not our fingers. Like, I feel like if we hurt the tip of our finger, we know exactly where on our finger we've hurt ourselves. But like, we have pain in the vulva, those pain receptors are not as specific. We can't isolate where that pain is as easily in our brains. So I think the Q-tip is super important. And, sometimes the vestibule will look red, especially as we touch it, if it gets this easy inflammation because it's had these inflammatory insults in the past. But sometimes it can also look normal. It doesn't really matter as much how it looks as how it feels to the patient.
Uh-huh.
But of course, we're also looking at the vulva in general, just to rule out any other kind of thing that could be going on, a dermatologic condition. I always do a swab to look for yeast, because if they have yeast growing on their vulva, that obviously would be a reason that they could have some inflammatory things going on, things like that.
Yeah, agree. And so many people, by the time they come to us, have been in the loop of, they've been told it's a yeast infection, they've been told it's a yeast infection. And I always try to reiterate to them that if you're in this loop and you're not getting better, there's a reason, because it's something other than that's causing you to have pain.
And, I'm sure we'll do a whole episode on yeast at some point, but patients often will tell me, I don't think I have yeast infection. I mean, sometimes people think they have lots of yeast infections, and actually do. But, we often think like a vaginal yeast infection. So inside the vagina, like cottage cheese discharge, itchy inside, but you can have a skin yeast infection on the outside that you don't necessarily have those symptoms, but it's still really itchy and inflammatory also. And then of course I'll evaluate the pelvic floor. And so those are, this is the 3 parts of this series, the Missionary Impossible, is thinking about hormones, thinking about the nerves, and then our last segment of this is about the pelvic floor. So I always put a gloved finger in the vagina and feel to see what the pelvic floor feels like, because that could definitely be playing a role in pain at the vestibule also. But today we're talking about the nerves. So let's keep talking about what we should do about these crazy nerves.
One other thing just to add is how it's affecting your mental health. Because again, so many people, this has been going on for so long, and it can cause depressive symptoms. I've seen people with suicidal thoughts from it. So I think it's important to address any mental health concerns as well when you have chronic pain.
Absolutely. I mean, this is different than like having neck pain or foot pain, right? Like that stuff is challenging and can definitely affect your mental health. But this is like such intimate pain. It's not something you can talk about very easily. And then it affects your relationship so much. Patients come to me all the time like, this is affecting my intimate relationship. Like my partner's super patient, but like we can't have sex. And just like the feeling of that failure every time you try to have sex and it's too painful, or, your partner doesn't want to hurt you. This has so much to do with our relationships and our self-confidence. And it's just such an intimate kind of pain. So I just think this is a much harder kind of pain. And so definitely checking in about mental health is super important.
Yeah. And then of course, we also always say vulva is a team sport. So do we utilize therapists and sex therapists in these scenarios? We absolutely do.
Yes, absolutely. Let's talk about how we treat this. So, I think first we educate. That's why we show people with a mirror where this is, because as a lot of clinicians don't know about the vestibule, a lot of patients don't know about the vestibule, although we're trying to change that.
Yep.
And so, showing them where the pain is, acknowledging that their pain is real. Like a lot of times patients are told, oh, just relax, have a glass of wine, you'll be fine. Like, yeah, it's ridiculous, right? Like this pain is real.
Yeah.
And sex should not be painful. Like Meredith said, It should not hurt.
Mm-hmm. It's so empowering, I feel, to people, especially when they've been to see so many providers, when you say, I understand your pain, and you validate it, and there's a name for this. This is neuroproliferative vestibulodynia. Like, say it, know it. This is what's happening. And so it's kind of that moment where, oh my God, I'm not crazy, because a lot of these people get told that. And it's unfortunate, I think in medicine so much that if you don't know what's happening with the patient, a lot of times they do get dismissed and kind of like, oh, it's all in her head and all that stuff. And that's not true. Like this is a real thing that causes real problems for people, not just themselves, but their relationships. And it sucks.
Yeah.
It's the worst.
Absolutely. And I think when we name it, it does validate it. It's like, yes, I haven't, this is real. Because I think patients start to doubt themselves of like, I know this is happening, but why can no one tell me what's wrong? And so, name it. Yeah. So sometimes we get pelvic floor physical therapists involved. So that's something that we'll talk about in our next episode, but definitely the pelvic floor can be part of the story. Even if mostly it's neuroproliferative, we tend to tense up with anticipatory pain, like anticipation of pain. Pelvic floor can be really helpful. And then I often start with neuromodulators. So Topical neuromodulators are my go-to. So a neuromodulator is a medication that changes the way your nerve endings communicate with your brain. So they're going to try to down-regulate that signal that these nerve endings are amplifying in your brain. So I start locally and see if I can affect those small nerves that are communicating to the brain. I really like topical gabapentin. It's a neuromodulator and tends to not have a lot of side effects. Other things we sometimes use, amitriptyline. Also, it's a tricyclic antidepressant, can have kind of down-regulate some of those nerve endings. And then sometimes triple creams with baclofen and sometimes even ketamine.
Mhm.
What are you similar go-tos,
Similar.
Meredith?
With this condition, like I will always start with topicals and pelvic floor physical therapy because that that
Yep.
is some collateral damage when pain's been there for so long and those muscles start to tense up. But I always will go with topicals. Now, and sometimes I will incorporate an oral medicine that's going to be
Mhm.
more going throughout your entire body. And these are medicines that are that help with nerve pain, but then also some of them just work in the brain to kind of down regulate those neurotransmitters or little chemicals that run down our nerves that help with pain and interpreting pain and help control pain. And those would be medicines like some of our antidepressants and anti-anxiety meds, which also can be used in chronic pain.
Definitely. So you can do gabapentin orally, amitriptyline, Cymbalta, those kind of things. I mean, it's not medical advice, but those are some of the things that I use. And I do agree, they down regulate that signal in the brain that's amplifying this pain.
Yeah.
They can have side effects, make people sleepy, things like that. That's why I like starting with the topicals because you're just putting it where you want it. This is such a small strip of tissue that can cause so many problems. So it's kind of nice to put it where we need it, and we'll have less side effects
And
with it.
and topically, there's really no absorption into the bloodstream from that
Right.
area. So we can pretty liberally use that. And really, you're just using a tiny, tiny amount. Like we're talking like just a small little lentil on your fingertip amount of the topical medicine. And it can help quite a bit for a lot of people. Now, I also think, again, every time you see somebody, you need to figure out where they are hormonally. Are you having your period? Are you not having your period? Or in a birth control pill? Because sometimes vulvar pain can be so layered. I used to always say it's kind of like a game of whack-a-mole. Like you're get one thing
Right.
better and then something else pops up. You're like, oh my God, I did not see that one coming. And hormones
Yeah.
can be one of those things that'll pop up on you. And, if they're on something like, or birth control pill that's affecting hormonally their tissue, maybe getting off of the inciting agent or putting in local hormone to the tissue as well to help if they're menopausal. Definitely local hormone therapy. I mean, vaginal hormones are the best medicine in the world. I think we all know that. And they, yeah.
Absolutely.
So that, they
Amen.
never hurt a soul on this planet. So sometimes it will incorporate that as well if needed.
Oh, we actually haven't talked about lidocaine. What are your thoughts about lidocaine?
I mean, I think some people kind of like will bash it. Sometimes you're not really getting to the root problem, but if you're
Yeah.
really having a flare, I mean, have I had people go, "Oh my God, my bladder hurts. I feel like I have a UTI. Like I'm really miserable." I'm like, you can actually just put a little lidocaine and see if numbing it will help. Now, we even in the clinic will do that to figure out where this pain is coming from. Where we'll put some really heavy duty numbing cream on this vestibule and then leave it on for a little bit, wipe it away, and then do that Q-tip test again. And then oh, my bladder symptoms are gone. That pain is not there anymore. And that's how we know. And that's proof that sometimes like local anesthetic can help a little bit. So I think if you're miserable and you need some help, it's totally fine. It's not hurting anything. Lidocaine preferred, not an irritant in the vulva.
I agree. What I don't like about it, and why I get kind of like lidocaine, is that sometimes people go to clinicians or providers and they're just told, "Here's some lidocaine.
Yeah.
Use this. Have a glass of wine." And so I'm not saying it's not a good tool, but it does not get to the root of the problem. To me, it's a band-aid. And I also think lidocaine often burns, especially if it's in a gel that has alcohol
Mhm.
in it. So some over-the-counter things can burn, and I feel like it just adds pain to it. And I always say, like, I don't want your vulva to be numb during sex. I just want it not to hurt, right? So I have like mixed feelings about lidocaine, but absolutely, if you're having unprovoked, like you're having just pain sitting there, and it's bad, I want your pain to go away anyway. We need it to, so I'm okay with lidocaine for sure, but I don't think it's like a great long term option.
Yeah. I mean, especially if you're still trying to get to the root cause and trying to figure things out. Like I said, it doesn't hurt anything if you were to use that. So, and then we talked about sex therapy, and we do definitely will utilize that. Sometimes people will do injections into the pelvic floor muscles or into the vestibule, things like trigger point injections, if like into tight muscles. That's something that also gets utilized sometimes in these pain syndromes.
Yeah. I have a couple patients that do really well with trigger point injections, even into the vestibule. But it's something that they have to do every 4 to 6 weeks. And so I don't have a lot of patients I do that with, but it's definitely something that I sometimes will try with patients and see if it makes a difference. I just find that it doesn't last all that long for a lot of patients. And so no, I don't think anyone really wants to get injections every couple weeks, especially in this area that already hurts. But like I said, I do have a couple patients that feel like that makes a big difference for them.
No,
But yeah, the sex therapist, and then it's like a pain therapist. Like, pain changes our brain, changes the way our brain functions and the way we think about things. And I think having someone kind of break some of that down and unlayer some of that and how it affects you and the emotions that go into it can be really helpful.
yeah. No, there is a surgery that can be done as well.
Yeah, if we can't fix it with something topical, then sometimes we cut it out because this area is causing a problem. And I think it's totally reasonable to start with topicals because sometimes they work. One thing I have patients ask me a lot is, well, if this works, do I have to be on this forever? And I always think that's a really great question. I think for patients who are born with this, like congenital neuroproliferative, I find that it's most of these topicals don't work
Agree. Mhm.
long term. Like they may reduce the pain somewhat, but ultimately I think these patients end up with a vestibulectomy.
Yeah, I agree. And I think I get in these scenarios with patients, and it's a big surgery, it's a big recovery, and really asking them, what's your goal here? Like, let's really talk about this before we really just go straight to having a surgery. And we've tried everything and topical, oral, and it's not helping. And, if your goal is to have pain-free penetrative sex and improve that part of your life, then I think it's, perfectly fine to do the vestibulectomy.
I try to frame it like this, like some of these things, like doing pelvic floor PT and putting things on the vulva is something that helps prepare you to do well after your vestibulectomy also, because even after the vestibulectomy, we often do pelvic floor physical therapy to help kind of help with those pelvic floor muscles. But definitely the congenital neural proliferative, people born with it, I find that the vestibulectomy is a really good option. For those that are acquired, meaning like they had an inflammatory event or something that happened and they ended up getting this condition, sometimes the topicals will work for quite a while. And I always tell patients if we can calm those nerves down long enough, we can try to taper down off this medication and see if they stay kind of at bay. And sometimes that works for patients for sure.
Yeah.
So vestibulectomy is basically we go to the operating room and we remove the vestibule. So usually we remove all the way around, not just that posterior, even though for a lot of patients it is just posterior. We really try to remove all of it because we know that these nerves kind of go all the way around. It's actually a fairly, you're taking such a small amount of tissue out. For the posterior part, we do generally undermine the vaginal tissue and kind of pull it out to cover it so that we're not putting tightening that area or narrowing the opening to the vagina.
Yeah.
It is a big recovery in the sense that you have a lot of stitches in your vulva, a lot of swelling at the beginning. It is not something that we just recommend the first time we see somebody.
Yeah. And it doesn't mean you failed if you have to have surgery. No, it's not your fault.
So there are pretty good success rates with it. I think it varies. I see some people that have 20 to 40% improvement. I see some people that have 90% improvement. So I think it kind of depends. I think one of the biggest factors here is choosing the right patient ahead of time, so that this is someone who is really the pain is just at the vestibule and there's not a bunch of other things going on. I have had a patient that was never able to have penetrative sex with her husband, was able to have penetrative sex after vestibulectomy.
Amazing.
So I definitely think that it can be life-changing for people.
All right. So I think takeaways here. What do we wish patients, providers, what do we wish that they would know about this condition in this part of the body?
I wish people knew what the vestibule was. Almost always it is the culprit. Almost always it is the problem. I mean, it's a problem place.
Yes, she deserves your utmost attention.
She does. She does. So, I mean, as a clinician, when I hear someone's having sex, pain with sex, the two questions I ask first, when does it hurt? Is it initial penetration or at the opening, or is it deeper inside? Yep. And if they see the opening, I'm telling you, almost 100% of the time, it's the vestibule. That's the thing I want people to know. And then I want people to realize that there isn't a dead end. There are options. I will be honest, this is one of the hardest things to treat in my mind, because it's not like this topical is going to cure you of this. It is something you have to do for 12 weeks, once or twice a day, put a topical on this area. And it takes time to see if it works. And we do like to try these topicals before we do the vestibulectomy, because I don't want you to have a surgery you don't need, and I want to make sure the surgery is the right thing for you. Mm-hmm. So I do find that this is a long road, but I do think that there are options to treat this.
This is a legitimate diagnosis, and there's a word for it, and there's ways to help you, and you should never have pain with any kind of penetration. And we can help you with this. And not everybody's going to look the same in their treatment plans, and not everything is going to work for everybody. But this is something that you work with your provider, and it takes time. It's not fixed overnight, but it can be helped quite a bit.
I think it's important to see someone who does a lot of this too, because I think when I was a generalist OBGYN, if someone came to me with this, I didn't have the tools then to really help people down this path. So I think trying to find your way to someone who does is really, really helpful.
Yeah.
This is kind of our summary of episode 2 of Missionary Impossible, when the front door is on fire, ouch at first touch. We really appreciate you guys listening. We're really excited about doing this podcast to really bring more attention to these problems, because so often patients go to so many people with painful sex or vulvar issues and don't get the answers they need. So we're really trying to provide that. If you are liking our content, please rate us on whatever mode of listening that you are using, like Apple Podcast or whatever. Give us a rating, give us a comment. If you have things that you want us to talk about, we have a whole long list of things we want to talk about, because we don't ever get sick of talking about the vulva. But if you have things you want us to talk about, let us know. You can send us a message. We're both on Instagram. I'm Ashley Fuller _MD on Instagram, and I'm trying to get my TikTok up.
Strong work.
So it's a little challenging for me. And Meredith McClure MD on Instagram.
Dr. Meredith McClure. And then, of course, Labia Logic is Labia _Logic.
Oh, yeah, that too. You can always just leave us a message there. Anyway, we appreciate you listening. And if you're having pain with sex, you shouldn't be. Go see someone. There's things we can do to help.
Yeah, it's not in your head, and wine isn't really going to fix it either. So,
no, and we believe you.
Yes, we do.
Thanks for joining us for this episode of Labia Logic.
We get it. Sharing a podcast like this might feel a little taboo, but we're here to break down those barriers. Labia Logic's all about empowerment, not embarrassment.
If you found this episode helpful, we hope you share it with others who could use a little Labia Logic in their lives. Can't we all? You can find us on all major podcast platforms and connect with us on Instagram at Labia _Logic.
From our lips to yours,
Viva la vulva!